ठीक है। Good evening, students. How's everyone? Are you able to hear me? Good evening, everyone. So, today we'll be discussing some MCQs from dental histology. Am I audible? Can you all hear me? Okay, so let's start with the first question. A 14-year-old patient presents with unusual chalky appearance on the incisal third of multiple anterior teeth. Upon examination, the areas are softer and show increased opacity. The patient's dental history reveals prolonged childhood illness around age 3 to 4, but no known high fluoride exposures, which best explains the nature of this enamel change. So, basically the question is telling about a chalky area on the incisal third. So, be it maxillary or mandibular, they both have some chalky areas on the incisal third, right? So, the question is, what does this defect relate to? So, the patient was ill when the patient was around 3 to 4 years of age, right? So, chalky, white and opaque, isn't it? Very good. Has to be hypomineralized, isn't it? Because in case it is hypoplasia, that means the matrix, there is defect in the matrix and the shape of the tooth would be defective, isn't it? But hypomineralization, that is chalky, there is lack in mineralization, the area that has less mineral, isn't it? So option B, that is hypomineralized enamel due to disturbed transition and maturation phase because the child was ill. So the ameloblasts, they were not doing their function properly, isn't it? So hypoplastic enamel arising from defective matrix deposition only, this is wrong. Excessive fluoride, we have already ruled out, there was no fluoride exposure. And a normal variant of Unterschläger, again this is incorrect. Unterschläger bands are seen in longitudinal section and they are an optical phenomenon, isn't it? Yes, very good. So the correct answer is option B. Let's go to the next question. So during a research project, a histology resident obtains high magnification images of actively secreting ameloblasts, right? He observes a prominent conical extension. So conical extension is there of the apical cell membrane forming two distinct surfaces, one for the enamel rod and one for the interrod. This topography is being investigated for how it organizes enamel crystals. Which feature is the student most likely studying? So basically they have described some features and they want to know what the feature is being studied or what the feature is being referred to. So options are reduced enamel epithelium attaching to the incisal region. Now reduced enamel epithelium means whole of the ameloblast or the post-ameloblasts. So here we are talking about the proximal or the conical surface of the ameloblast, that is the distal surface of the ameloblast, isn't it? So we are talking about the distal surface, but this is talking about the entire ameloblast. So option A is incorrect. Tomes process guiding rod and interrod enamel deposition. So we know that the distal surface of ameloblast appears something like this, isn't it? So the Tomes process, this is responsible for the head region, isn't it? Head region or the rod region, and the rest of the peripheral surface of the enamel. The peripheral surface of the enamel, that is responsible for interrod, isn't it? It is responsible for interrod enamel or the tail region. So this peripheral region, it has different orientation of hydroxyapatite, and this would form tail, and the Tomes process region that has different orientation, or the orientation of hydroxyapatite here is parallel to the long axis. As you can see here, the crystals are parallel to the long axis, and this is the head or the rod region, isn't it? So for this question, option B, that is Tomes process guiding rod and interrod enamel deposition, is the correct answer. Now option C, odontoblastic process that crosses the DEJ, known as an enamel spindle. So we are not talking about enamel spindle, we are talking about an extension between the ameloblasts or within the enamel. See what it is talking about: actively secreting ameloblasts observes a prominent conical extension of the apical cell membrane. So the cell membrane is extending, isn't it? So we can easily rule out option C, isn't it? Odontoblastic process, that is a part of odontoblast, not of ameloblast. And option D, stratum intermedium cells that concentrate alkaline phosphatase. Again, these are located proximal to the proximal side of the ameloblast. These are not ameloblasts, right? So option B is the correct answer. Very good, Bhavna. An intact longitudinal section of a recently extracted molar is studied under polarized light. Short branching hypomineralized extension from DEJ towards the inner third of enamel was noticed. They have a characteristic brush-like appearance, isn't it? They have a characteristic brush-like appearance or shape. During clinical procedures, they can occasionally serve as pathway for caries spread if enamel surface is breached. Which structure does this description most closely fit? So let's say this is the DEJ, this is the surface, and then we have some brush-like extensions going from DEJ towards the surface, but they are restricted within the inner one-third, isn't it? They are restricted within the inner one-third. So what do you think would be the correct answer here? Bhavna, Arpita, and the unknown person. So what do you think is the correct answer here? Is it option A, B, C or D? Is it enamel spindle, tuft, pericamata or lamellae? So as we can see from this drawing, right, and also from the description, it is restricted within the inner third. Also, it has a brush-like structure, or you can say a tuft of grass-like structure, isn't it? Short, branching, hypomineralized. So all of this fits enamel tufts. See, enamel spindles, they do not appear brush-like. They appear more or less like a comma, isn't it? They appear more or less like a colon, comma, isn't it? They appear more or less like a colon or a comma, isn't it? They are also hypomineralized. They are also short, right? And they are also restricted to within a short distance from DEJ, right? Again, pericymata is the surface expression of Stryophragis, so we can rule it easily out. Enamel lamellae. What are enamel lamellae? These are leaf-like structures or leaf-like defects extending from surface to DEJ, right? So these cover the entire thickness of enamel, but here we can see that they are restricted to inner third. So option B, that is enamel tufts, is the correct answer. Yes, very good everyone. B is the correct answer. So next question, a radiograph shows a slightly opaque region in the cervical third of a canine root, dentine. Clinical records indicate chronic mechanical abrasion of the cervical margin from aggressive brushing. Over time, tubules appear obliterated by a translucent deposit. This phenomenon is best described as. So, I think the question is relatively easy, isn't it? You can easily understand what this question is talking about. You took a radiograph and a particular area appeared more opaque as compared to the adjacent tissue. And we know from the clinical history that the patient has a habit of aggressive brushing. So there is mechanical trauma, and because of this mechanical trauma, what has happened? The entire dentinal tubule has become obliterated, isn't it? With a translucent deposit. So translucent deposit entirely obliterated. This suggests what type of tissue? The only tissue that is translucent is in the dentine. Obliterates the dentinal tubule is sclerotic dentine, isn't it? It is the sclerotic dentine that deposits, that reduces the tubular lumen, isn't it? A linear enamel extension, obviously we are talking about dentine. So within the dentine there is no enamel extension. Intrinsic root discoloration from prior trauma. We are not talking about discoloration, we are talking about deposition, isn't it? Hypercementosis around the cervical margin. Again, this is incorrect because we are talking about dentine and not cementum. So let's go to the fifth question. During a forensic analysis, ground section of an incisor. So this is the ground section of an incisor, which shows evenly spaced dark lines paralleling the dentino-enamel junction and crossing dentinal tubules. Occasionally, accentuated thicker dark lines are also noticed. Which histological feature best matches this description? So which histological feature would best match this description? So there are lines which cross the dentinal tubules, isn't it? Let's say these in red are the dentinal tubules, the blue ones are the dark lines, and then here we have the DJ, right? And in between these lines we also have some dark lines, right? So what is the question talking about? Which feature are we talking about? So basically, when there are regular lines seen within any tissue, be it enamel, be it cementum, be it dentine, they are referring to incremental lines, isn't it? They are referring to incremental lines. Now let's take a look at the options. Hunter-Steger band crossing the tubules obliquely. Now Hunter-Steger bands, first of all, in the dentine there is only a single pair, isn't it? And it is seen because of the overlap of primary curvature of the dentinal tubules, right? Second, incremental lines of von Ebner with possible contour lines of Owen. Now, when you read the question, you would realize that it is talking about dark lines with some accentuated lines, isn't it? With some accentuated lines. So these accentuated lines, these are not regular occurrence. These are irregular occurrences, isn't it? Or chance occurrences. So obviously, it is talking about regular lines and some irregular lines. So irregular lines, as I just said, these would be incremental lines, and the weekly or the 5-day line in the dentine is the incremental line of von Ebner, and then the contour lines of Owen are produced due to overlap of the secondary curvatures, right? Due to overlap of secondary curvatures of dentinal tubule, isn't it? So some contour lines of Owen would be seen, and most of these lines are incremental lines of von Ebner, isn't it? I'm extremely sorry. Incremental lines of von Ebner are daily lines. They are not 5-day lines. 5-day lines are lines of incremental lines of Anderson. So these Anderson's lines, these are 5-day lines, and the von Ebner's lines are daily incremental lines, right? Option C, cross striations. These cross striations are seen in enamel, not in dentine, and again these are daily incremental lines. Dead tracts, they are just empty dentinal tubules, isn't it? So option B is the correct answer. So let's go to the next question. During a routine histological examination of extracted premolars, a student observes distinct layered zones in coronal pulp, right? After the odontoblast layer, there appears a cell-free region containing nerve bundles and capillaries, followed more internally by a dense aggregate of fibroblast-like cells. Which arrangement best describes these pulpal zones? So basically, when you look at this question, what you would realize is that only the last part is sufficient. Which arrangement best describes the pulp zones? So even if you had read this last part, you would be able to answer this question. Sometimes it happens that most of the question is made up of sentences that are not important, but the last part would help you to answer the question, right? So whether we read this initial part or we didn't read this initial part, that would not make any difference, right? So which arrangement best describes the pulp zone? Again, since there is pre-dentin also in the options, we know that just adjacent to the pulp is dentin, and just beneath the dentin, the unmineralized region of dentin, that is pre-dentin. Beneath it is the odontoblastic zone, beneath which is the cell-free zone, and beneath the cell-free zone is the cell-rich zone, and beneath the cell-rich zone is the pulpal core, isn't it? So option B again is the correct answer. Odontoblast, cell-free, then cell-rich zone, and then the pulp core. So zone of Weil or cell-free zone, right? So I think this was relatively easier. Actually, all the questions are easy. If you read them properly, you will find that all the questions are easy. So a patient reports brief sharp pain. So there is an acute, or you can say there is a brief sharp pain upon exposure to cold. The dentist discusses that pulp's nerve supply is unique for detecting and transmitting stimuli that the patient perceives mostly as pain. So we all know that most of the stimuli are perceived as pain by the pulp. In fact, not most, but all the stimuli is perceived as pain, isn't it? So which statement best explains the neurovascular arrangement in pulp that underlies this phenomenon? So basically, the question wants to know about the question is talking about the nerve supply of the pulp or the nerves present in the pulp. So pulp contains only unmyelinated C fibers, providing dull, lingering ache. Second option, myelinated A delta fibers. It's only now that I am realizing that for all the questions, somehow I have gone with option B as the correct answer, isn't it? So somehow it has happened that all the option B's are correct. So myelinated A delta fibers branch within the subodontoblastic plexus to transmit fast, sharp pain. So from one fiber, remember this extra information that there comes out approximately 8 branches, right? From one fiber, there comes out approximately 8 branches in the cell-free zone of Weil. So basically, it forms a very rich plexus, isn't it? And another thing that you can remember is that a single fiber covers an area of approximately 1 lakh square microns, right? 1 lakh square microns. So that much area is covered by a single fiber, nerve fiber. Clear? So let's go to the next question. So basically, there are both myelinated and unmyelinated fibers. Unmyelinated fibers are the C fibers, and myelinated fibers are A delta and A beta fibers. So A beta are larger and they are more rapidly conducting fibers, but then A beta are very scarce, right? They are very few in number. So most of the myelinated fibers, they are the A delta fibers, right? They are the A delta fibers. So C fibers are responsible for dull pain, chronic pain, isn't it? And A delta fibers for acute pain, for sharp pain, right? So C fibers, C for chronic, A fibers, A for acute, right? A patient has undergone prolonged orthodontic treatment to correct crowding. After 2 years, mild root resorption is observed radiographically on the affected incisors. So, let's say the patient went for an orthodontic treatment and there was a resorption on the root, on the affected. However, certain areas of the cervical and mid-root surface show new mineral deposition that appears continuous with existing cementum, right? So it is continuous with the existing cementum. It is continuous with the cementum. Which process best explains this separative phenomenon? So what has happened is that there was a resorption of the root and then deposition of cementum took place in that lacunae, isn't it? Cementum deposition took place in the lacunae. We have studied in the class that repair takes place in two ways, isn't it? Anatomic or physiological. So in the anatomic repair, there is a repair of the boundary of the root, isn't it? As I have drawn in this diagram. So there is a restoration of the boundary, but in functional repair, only there is a reattachment of the periodontal ligament fibers, isn't it? Absolutely, it's option B. But important is to understand the question and the options. So osteoblastic activity on the root surface, obviously there is cementum deposition, isn't it? It's the repair of the root surface takes place by cementum. And then option B, cementoblasts depositing cellular cementum in resorption lacunae. So as we just discussed, it is the cementoblast that is responsible for the repair of the root surface resorption, isn't it? So they can be either anatomic repair or there can be functional repair, isn't it? So what happens in the anatomic repair? The anatomic outline of the root is restored, isn't it? So as I have just drawn here, let's say this is the resorption. So if this outline, so if the outline of this root resorption is restored, then it is an anatomic repair. And let's say this is another case where there was resorption and here only sufficient cementum was deposited to regain the periodontal ligament attachment, isn't it? So this is the functional repair, right? Functional repair. So gingival fibroblasts generating extrinsic fiber to fill the void. So gingival fibroblasts, they do not generate the extrinsic fiber. It is the periodontal ligament fibroblasts, the fibroblasts found within the PDL. Rapid alveolar crest expansion encroaching on the root. So again, this is incorrect and doesn't make any sense. So next question, a new graduate dentist wonders why alveolar bone quickly remodels under orthodontic load, whereas cementum does not extensively resolve or remodel. So first thing is the bone remodels and the cementum does not. In the same manner, which factor distinguishes cementum from alveolar bone in this context? So why does the bone resolve and why does the cementum not resolve? So why does the cementum not resolve and why does the bone resolve? What is the difference? So options are: cementum has an abundance of osteoclast precursors. Cementum has no Sharpie's fibers to transmit tension. Cementum typically lacks vascularity and continuous turnover. Cementoblasts are replaced every 2 to 3 days by, so basically this is talking about turnover, isn't it? So we all know that cementum is avascular tissue, isn't it? It is avascular tissue and that's why it neither can resolve nor it can be turnover or recycled, isn't it? So obviously when pressure is applied, in response to that pressure, monocytes are recruited as either odontoclasts or osteoclasts or some other class cell, right? But these are derived from the blood, isn't it? So since cementum is avascular, no class cell can be recruited, isn't it? Since it is avascular, no class cell can be recruited and that's why cementum cannot be resolved. Cementum does not resolve, isn't it? Unless excessive force is applied. So unless excessive force is applied, it is the bone that will resolve and not the cementum. So the next question, a researcher studying synovial joint notices that TMJ's articular surfaces differ substantially from those of classic long bone joints. See, long bone joints, they are lined by hyaline cartilage, isn't it? After preparing stained section of a human mandibular condyle and glenoid fossa, she realizes these surfaces aren't lined by hyaline cartilage, as I just told you. All the other joints, they are lined by hyaline cartilage. What tissue is primarily seen covering these TMJ articular surfaces? So which tissue lines these articular surfaces? Options are dense fibrous connective tissue, hyaline cartilage with abundant chondrocytes, elastic cartilage specialized for tensile strength, and osteoid matrix contiguous with alveolar bone. So what do you think would be the correct answer here? Is it the dense fibrous connective tissue, is it the hyaline cartilage or the elastic cartilage or the osteoid matrix? क्या इसका सही आंसर होगा? अभी तक आपने सबके आंसर्स दिए और बिल्कुल सही दिए. So what would be the answer for this question? Very good, Bhavna. Very good everyone. है ना? It is the dense fibrous connective tissue. Basically, the condylar or the glenoid fossa articular surface. These are both lined by fibrocartilage, isn't it? These are both lined by fibrocartilage. These are both very good everyone. Yes, dense fibrous connective tissue. These are both lined by fibrocartilage, isn't it? So let's go to the next question. An oral surgeon is discussing the significance of specific TMJ ligaments in preventing excessive motion. The patient's imaging reveals a sprain-like injury around the capsule. So there is an injury around the capsule. Which ligament primarily reinforces the lateral aspect of the TMJ? So basically the important part of this question is which ligament primarily reinforces the lateral aspect of TMJ capsule to restrict displacement of the condyle. So as I told you, sometimes it would happen that most of the question it won't be necessary to read, right? So you won't need to read the entire question. Just the last part sometimes is sufficient to answer the question, right? So options are sphenomandibular ligament. So sphenomandibular ligament connects from spine of sphenoid to lingula, isn't it? Spine of sphenoid to lingula, and spine of sphenoid to lingula, it would be seen close to the lower border of the mandible, isn't it? It is present close to the lower border of the mandible, and both of these ligaments, they have some role to restrict the depression of the mandible, isn't it? To restrict the depression of the mandible. Pterygospinous ligament, again pterygoid plates, they are found in the posterior region of the skull, isn't it? So not the posterior, in the middle portion of the skull. So basically they will be related to the posterior portion of the mandible, isn't it? So, and we haven't even studied something called pterygospinous ligament, something coming out of pterygoid plates. We haven't studied any such ligament, right? So we already only know about these three ligaments. So has to be one of these three. So as I just said, the top two ligaments, they are associated with the lower border of the mandible. So they can't be, right? Even if you don't know about them, just read their names. Sphenomandibular ligament, stylomandibular ligament, styloid process, sphenoid process. So both styloid process and sphenoid process, they would be somewhere here, isn't it? Beneath the condyle, isn't it? They would be beneath the condyle, beneath the level of the condyle, isn't it? They would be somewhere around the lower border of the mandible, isn't it? They would be close to the lower border of the mandible. So these can't be your answers. D we have already ruled out. So even if you don't know about this particular ligament, you can easily rule out, isn't it? You have to correlate. Correlate करना पड़ेगा ना अपने को कि स्टाइलोमैंडिबुलर की क्या पोजीशन हो सकती है, स्फिनोमैंडिबुलर की क्या पोजीशन हो सकती है, स्पाइन ऑफ स्फिनोइड कहां पर होता है, स्टाइलॉइड प्रोसेस कहां पर होता है, राइट? Temporomandibular ligament. The name itself says it is TMJ ligament. So has to be at the TMJ. TMJ ligament has to be at TMJ, isn't it? That's why it is called TMJ ligament. It is also known as lateral ligament, isn't it? It is also known as lateral ligament, and we are concerned with the ligament that restricts the lateral displacement. So basically, let's say this is the TMJ covered by the capsule. So beneath it you can see the condylar neck coming out like this. So this is the capsular ligament, and on the lateral surface of this capsular ligament there would be a fan shape. There would be a fan shape thickening of this particular ligament, particular capsule, and this fan shape thickening of capsule is what is known as this lateral ligament or the temporomandibular ligament. Correct? Is it clear? Always remember that these names, they are not random. Random name हम रखते ही नहीं है कभी भी, है ना? We study a particular feature and we find the easiest way to remember that particular thing, and that's how we name it. तो spine और sphenoid और mandible को जोड़ा था sphenomandibular, styloid process और mandible को जोड़ा था stylomandibular ligament, temporomandibular ligament. Why? Because it was seen at TMJ, right? So that's how you can get to your answer even if you don't exactly know what it is. So option C is the correct answer. Is it clear? तो हमेशा पढ़ाई से ही सॉल्व नहीं होगा, कभी कभी हमें दूसरी तरीके से भी सोचना पड़ता है, राइट? While examining a submandibular gland section under the microscope, a researcher notices most acini composed of pyramidal cells. So most of the acinis are composed of pyramidal cells with granular cytoplasm. So granular cytoplasm, why? Because all these secretory organelles, they are arranged like pearls, and this is known as zymogen granules, isn't it? So these granular cytoplasm and spherical nuclei. So the nuclei is spherical, the cell is pyramidal, and the nuclei is spherical, and then there are zymogen granules, but also some mucous acini capped. So there are also mucous acini, and these mucous acini are capped by a crescent of serous cells. So these are capped by a crescent of serous cells. These crescent-like arrangement is best described. So what is it best described as? What is it best described as? So what is the correct answer? Purely serous acini, demillions of one abna, crescents of, I don't know how to pronounce this. इसे कैसे pronounce करना है वो मुझे नहीं पता, जियानुजी शायद या जो भी कुछ है, और demillions of Heidenhain and myoepithelial basket cells. तो क्या correct answer होगा इसका? Now if we don't know what the correct answer is, we can easily rule out option B, demillions of wall abnus. What is that? Myoepithelial basket cells. No, myoepithelial cells, they are associated with acini, but that is a single cell, isn't it? Purely serous acini. Yes, these are purely serous acini, but that is not the question. That is not exactly what the question is asking about, isn't it? The question is asking about the name of these crescent-like arrangement. So their name is crescents of Giannuzzi or demillions of Heidenhain, right? Yes, you can get confused with this demillions of one abner because we haven't studied any of B or C. But just remember that the option C, this is the alternate name for serous demillions, right? We also call them serous demillions because these serous demillions or these crescents, they are made up of pure serous acini, isn't it? They are made up of pure serous acini. So what are these crescent shaped structures? They are pure serous cells. But what are they described as? They are described as serous demillions, isn't it? So when the question is asking about what are they described as, they are talking about the name, isn't it? Thank you, Bhavna. So this time I just tried to make the language tough, but the questions easier. क्योंकि एग्जाम में कई बार ऐसा ही होता है कि क्वेश्चंस की लैंग्वेज जो है वो लैंग्वेज टफ होगी थोड़ी. इनफैक्ट इट वुड बी लेंदी टू मेक इट अपीयर टफ, बट द क्वेश्चन इन रियलिटी इज वेरी इजी. जैसे कि यहां पर सारे ही क्वेश्चंस आसान हैं. A patient has compromised salivary secretion with low pH, right? The dentist suspects an issue in the ductal system that normally helps adjust electrolyte composition of saliva. Which duct region is chiefly responsible for actively modifying ionic content and pH of the primary salivary fluid? So again, this is one of those questions where just reading the last sentence is sufficient to answer the question. Which duct region is chiefly responsible for actively modifying ionic content and pH of the primary salivary fluid? We know that the primary fluid or the initial saliva is isotonic, but the final saliva that is secreted in the oral cavity, that is hypotonic. And this is because sodium and chloride are removed from the saliva and bicarbonate and potassium are added, isn't it? And which duct does this thing? It is the striated duct. But I have no idea about predictor series, so maybe we can talk to Mahendra or someone in the office and we'll get to know about the predictor series. So intercalated duct, what does the intercalated duct do? It secretes lactoferrin and lysozyme. So that is the role of intercalated duct in modifying the saliva. It secretes lysozyme and lactoferrin. And striated duct, as I just told you, it removes sodium chloride and it secretes potassium and bicarbonate. Intralobular or interlobular excretory duct or the main excretory duct, this is one and the same thing. So excretory duct, they don't have much role in the saliva modification, isn't it? They just transmit the saliva from striated duct into the oral cavity, right? So let's go to the next question. A periodontist notes that in a patient with chronic periodontitis, the probing depth has extended beyond CEJ. So probing depth has gone beyond CEJ, revealing a significant loss of attached gingiva. So attached gingiva has receded. Histologically, the junctional epithelium or the epithelial attachment appears apically displaced. So as I just said, gingiva has receded. Which statement best describes the significance of junctional epithelium's role in health? So which statement best describes the significance of the junctional epithelium's role in health? So this much of the question is sufficient to get your answer, isn't it? It is purely a structural junction for alveolar bone anchorage. So junctional epithelium does not anchor the bone, isn't it? It provides a seal between the tooth surface and the oral environment, limiting bacterial ingress. It continuously produces cementum. Cementum is produced by cementoblasts. It serves as the main reservoir for salivary IJ secretion. So that would be done by the salivary glands, not by the junctional epithelium. So what is the correct answer? It forms a junction with the, or why do we call it attachment epithelium? We call it attachment epithelium because it attaches the oral mucosa to the tooth, isn't it? So basically it's a seal around the tooth, isn't it? So the junctional epithelium forms a junction with the tooth and these are hemidesmosomal junctions, isn't it? So with the help of hemidesmosomal junctions, the junctional epithelium attaches to the tooth. Is it clear? So the mechanism of attachment of tooth to the junctional epithelium, that is hemidesmosomal attachment. Right? And what is the structure that helps in the attachment? Or this attachment is via lamina lucida, isn't it? There is only lamina lucida on the side of the tooth and both lamina lucida and densa on the side of connective tissue, right? So the correct answer here would be option B once again. So I hope today everyone is enjoying solving these MCQs, isn't it? They are relatively easy, predictable, and even if you don't know the exact answer, you can somehow reach to the correct answer, isn't it? In a biopsy from the buccal mucosa, an oral pathologist identifies a dendritic cell within basal and suprabasal layers that does not synthesize keratin. This cell is positive for Langerin or CD207 on immunohistochemistry. So Langerin or the other name is CD207. So it is positive for Langerin and it does not synthesize keratin. So basically it is a non-keratinocyte, isn't it? What is the most likely function of this cell type? So iska kya function hoga? Options are initiating pigment formation, providing tactile sensation, serving as an antigen presenting cell, or secreting antimicrobial peptides directly into the salivary flow. So what would be the answer here? Now what is Langerin? So Langerin name itself gives you a hint of the answer. Langerin or Langerhans cell, isn't it? Langerhans cell, what do the Langerhans cells do? They are antigen presenting cells, and we know that the Langerhans cells, these are present in both basal and para-basal tissue, isn't it? They might be present in the basal or para-basal, wherever they want, isn't it? And they are non-keratinocyte, so they do not produce keratin. Clear? And they are also dendritic. So which other cell is dendritic? It is the melanocyte which is dendritic. Option B, Merkel cells, these are non-dendritic and they are sensory. So this Langerin, basically it is a transmembrane protein, right? Langerin or CD207, this is a transmembrane protein and it helps in binding antigen. So this protein, this transmembrane protein, it traps the antigen. It helps in binding to the antigen. Clear? So option B, that is option C, that is serving as an antigen presenting cell, is the correct answer. So let's go to the next question. So a researcher is studying mouse embryonic oral epithelium and underlying ectomesenchyme to determine how the dental lamina begins to form. She finds that signals from ectomesenchyme direct the epithelium to produce the tooth bud at a specific site. Which statement best describes the foundational process? Bhavna, dendritic cells are Langerhans and melanocytes. Non-dendritic cells are lymphocytes and Merkel cells. Right? Merkel cell is a sensory cell, so that is non-dendritic, and lymphocytes, they are also non-dendritic. So phagocytic हो सकते हैं, right? So they are non-dendritic, but antigen presenting cells, they have to trap the antigen. They are dendritic, and again melanocytes, they synthesize melanin and they have to transport this melanin into the adjacent epithelial cells or the adjacent keratinocytes. So it is again dendritic, and one melanocyte is associated with approximately 30 adjacent keratinocytes, right? The ectodermal enamel organ solely instructs mesenchyme to begin tooth development. So basically the question is talking about epithelium ectomesenchyme interaction, isn't it? It is talking about epithelium and ectomesenchyme interaction. And during the class we have studied that the epithelium and the underlying connective tissue, they interact with each other. They each secrete some of the growth factors, isn't it? So epithelium, it produces Pitex2 and FGF8, whereas in response to FGF8, in the oral in the ectomesenchyme, LHX6 and 7 is produced, and what else is produced? PAX9. So that is how the oral axis is established, and that is how the tooth bud initiation also takes place, right? So basically there is an interaction between the epithelium and the ectomesenchyme, and there are several other growth factors as well, isn't it? So what happens is epithelium and ectomesenchyme interaction. So we have seen this interaction everywhere, even during the hard tissue formation, isn't it? So pre-ameloblast, it produces some growth factors and it stimulates the dental papillary cells to differentiate into odontoblasts, and these odontoblasts, they will in turn secrete dentine, or they will form the dentine, which will stimulate the pre-ameloblast to convert into ameloblast. So there is continuous interaction or mutual stimulation between epithelium and ectomesenchyme, right? So you have to find the option which describes this interaction, and that will be your correct answer. So the ectodermal enamel, so here basically it is talking just about the ectoderm. The dental lamina forms passive link with no molecular. So again this is incorrect, because there has to be some amount of some sort of stimulation. Tooth bud formation results from reciprocal interaction. So yes. Option C is talking about reciprocal interaction between epithelium and ectomesenchyme. So option C is the correct answer. Enamel navel. Again, this enamel navel is a temporary structure which is seen in the cap stage. So what is enamel navel? So let's say this is the cap stage of the enamel organ and this is the enamel knot. So sometimes the enamel cord extends to the outer layer of the tooth germ, that is beyond the outer enamel epithelium to the basement membrane. So in that case, what happens is there is a depression seen at the site of this attachment. There is a depression on this outer membrane at the site of this attachment, and this depression is known as enamel navel. This depression is known as enamel navel. So this is a temporary structure seen in cap stage. So next question, a graduate student observes an embryonic tooth germ transitioning from a simple bud of epithelial cells into a more complex structure with a concavity on its deep surface. Concavity on the deep surface. I guess you all know now what we are talking about. So histologically an enamel knot appears. Which developmental stage does this description most closely match? Bud, cap, bell और अपोजिशन स्टेज. सो बट था, बट से वो स्टेज आ गई जिसमें कि थोड़ा सा कॉन्कैविटी है प्लस इनेमल नॉट भी है. सो विच स्टेज इज दिस क्वेश्चन टॉकिंग अबाउट? इट इज टॉकिंग अबाउट द कैप स्टेज, isn't it? Cap stage. Apposition would be seen in late bell, isn't it? It would be seen in late bell. Yes. Option B is the correct answer. So next question, at the bell stage, the inner enamel epithelium, stratum intermedium, ciliate reticulum and outer enamel epithelium are clearly identifiable. So first of all, the question is telling you that all these cells are identifiable in the bell stage. A critical change occurs soon as the inner enamel epithelial cells differentiate into ameloblasts. So as soon as they differentiate into ameloblasts, a critical event occurs. And what is this critical event? It is the formation of enamel. So what major event triggers this differentiation? So the question is asking about the differentiation of ameloblast or the trigger factor that stimulates the pre-ameloblast to convert into ameloblast. So that is what the question is asking about, isn't it? So options are dental sac producing Hertwig's epithelial root sheath around the cervical loop. So option A is about root formation. Odontoblast secreting the first layer of predentine next to the inner enamel epithelium. Yes, this is the correct answer. And we have just seen in the previous question that there is a continuous interaction between epithelium and ectomesenchyme, and that's how these tissues are formed, isn't it? So option B is the correct answer. So predentine secretes growth factor which stimulate the dental papilla to convert dental papillary cells to convert into odontoblast, and these odontoblasts then would secrete dentine, and this dentine would stimulate pre-ameloblast to convert into ameloblast, isn't it? So the correct answer is option B. So next question, an 8-year-old patient's radiograph shows a permanent mandibular incisor emerging into the oral cavity. So the tooth is erupting, yet its root formation is only about half complete. So its root is only half formed. The parent wonders why the tooth is erupting before the root is fully formed. Which statement best addresses this observation? So what do you think would be the correct answer for this question? Tooth eruption never begins until root formation is complete. Eruption is driven exclusively by the rate of root elongation or root formation. The dental follicle and alveolar bone remodeling drive eruption. Root formation continues afterwards. The epithelial rests of molasses induce eruption through cementum resorption. So, what do you think would be the correct answer here? Which option is correct? Yes, very good. Option C. So, because of the eruption, a apically space is created. So, as the tooth moves occlusally, space is created apically, isn't it? As the tooth moves occlusally. So let's say only half of the root is formed. So as it moves occlusally, space is created apically, and in this space, then root formation will take place, right? So we have studied in the class different theories for eruption. Root formation theory was one of them, which said that as the root forms, upward thrust is applied and the root erupts. But later on we found that the theory was incorrect, isn't it? So it is because of the eruption that the root formation occurs. So option C is the correct answer, right? So let's go to the last MCQ. A child aged 7 has a retained primary incisor with the permanent successor visible. So permanent successor is also visible and it is visible palatally. The root of the primary tooth remains only partially resolved. Which factor is most likely responsible for delayed shedding of this primary tooth? So which of these factors has led to delayed shedding of the primary tooth? Options are defective or absent primary successor. Option B, lack of adequate mechanical stimulation on the primary tooth's root surface. So yes, this option does make sense since the tooth is more palatally positioned, the succedaneous tooth. There would be a definite lack of adequate mechanical stimulation, isn't it? Because it is the erupting succedaneous tooth, the pressure it applies which leads to root resorption. So option B does appear correct. Option C, ectopic eruption path of the permanent tooth not contacting the primary root. Now when we read this option C, we find that the option C is more appropriate, isn't it? Though option B, you can say, is also a correct option. Option C is also correct. But which is better of these two? It is option C, because it is giving you a more accurate description, isn't it? Option D is insufficient alveolar bone growth around the tooth jaw. So again, option D does not make any sense. So option D and A can be ruled out. Amongst option B and C, option B is more of a general statement, whereas option C is more specific, isn't it? So option C is the correct answer. So always remember, solving an MCQ is not always about finding the correct answer. Sometimes it is about finding the best option. So sometimes there may be more than one correct option. So in that case, we have to see which statement is better, right? Of the correct options, which is the better statement. So here, as answered by Pankti, option C is the correct. Very good, Pankti. Though I tried to confuse you a bit, but you got the correct answer and very good. So do you have any questions? Do you have any questions? I hope you were all able to solve this paper correctly today, isn't it? So I guess you don't have any questions. So let's meet tomorrow at 8 again, and hopefully I'll again post the paper on the group. So if you don't have any questions, then let's meet tomorrow. Good night. GF for reciprocal induction. So in the class we talked about several growth factors, isn't it? Some of them are responsible for the morphology of the specific teeth, isn't it? Like MSX, DLX, BARX. So all those were responsible for the morphology. Then there are some some growth factors which are responsible for the oral aboral orientation of the tooth. For example, FGF8. But then we need to organize the tooth jump into a particular position, right? So that is the oral aboral, so that the crown erupts in the oral cavity and the root remains in the alveolar bone. So FGF8 is expressed in the epithelium and it induces the It induces the expression of LHX 6 and 7 in the ectomesenchyme. So there is a interaction between ectomesenchyme and the epithelium, right? And that is how the tooth bud forms. If there is an absence of FGF8, then the tooth bud will not form, because absence of FGF8 will lead to absence of LHX 6 and 7, and the tooth formation would be interrupted, or would be it would be suspended at dental lamina stage, right? So it won't move ahead of dental lamina, right? Similarly, if we look at the interaction between epithelium and mesenchyme, or the dominant role, you would realize that up till cap stage, the epithelium of second pharyngeal arch has the dominant role. So if we combine any ectomesenchyme with this epithelium, a tooth would form. Beyond cap till late bell, right? Beyond cap till late bell, sorry, from cap to bell stage, from cap to late bell stage. So cap to late bell stage, ectomesenchyme has the dominant role, right? So if you combine any epithelium with this ectomesenchyme of the second pharyngeal arch, you would still get a tooth. So ectomesenchyme takes the dominant role. In the late bell stage, so in the late bell, so first stage till the cap stage, till the beginning of cap stage, that is in the entire bud stage, the epithelium is the dominant. So from dental lamina to the bell stage, it is the epithelium that has the dominant role. Cap to late bell, it is the ectomesenchyme that has the dominant role. And then in the late bell, once the membrana preformativa has established, then again the epithelium has the dominant role. So the epithelium would decide which type of tooth will form. And at this time, the histodifferentiation ability is lost. Now, the epithelium cannot regulate the histodifferentiation of ectomesenchyme. So only if odontogenic ectomesenchyme is fused with the odontogenic epithelium, a tooth would form, right? So let's say a canine enamel organ is fused with a molar ectomesenchyme. It would result in the formation of a canine, right? Because at the end, or ultimately, the membrana preformativa or the epithelium, it takes the dominant role. So now, fusing an odontogenic ectomesenchyme with an odontogenic epithelium would result in the formation of a tooth. But instead, if we used an ectomesenchymal tissue from some other place, it would not result in the formation of a tooth, because historegulation is lost now. So this epithelium cannot regulate the differentiation of the ectomesenchyme. Is it clear now? The interaction between the ectomesenchyme and the epithelium. And also FGF8, LHX6, these are the growth factors. So FGF8 stimulates the secretion, stimulates the expression of LHX6 and 7. So at the place of LHX6 and 7, this is for the root, and FGF8 describes where the crown of the tooth would appear or would be aligned, right? So basically they establish the oral aboral axis. So these two, they will describe the oral aboral axis, right? PAX9 similarly is responsible for patterning. So which tooth will form at which place? Incisors in the mesial most and molars at the distal most. So that is described by PX9. Again, BMP2 and 4, those are inhibitory. They are expressed in the intradental region, right? FGF8 is expressed in the dentate area, right? BARX is expressed in the molar region, and ALX is expressed in the incisor region. So that's how these growth factors, they will regulate the formation of tooth buds or specific tooth buds at specific location. Pankti, I hope it's clear now. So apart from these, we also have two other inductive growth factors like SHH and WNT. So they are also responsible for induction, right? And BMP2 and 4, that is inhibitory. Is there any other doubt? Any other question? Any other question? Bhavna, Pankti, Arpita, anyone else? So let's meet tomorrow at 8. Okay. Good night.